Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jessica Adams. This episode features content from an educational webinar titled Answering the Questions on Which HIV PrEP for Which Patient, featuring Dr. Latesha Elopre and Dr. Jason Farley. Dr. Elopre is an associate professor in the Division of Infectious Diseases and Assistant Dean of Diversity and Inclusion for General Medical Education at the University of Alabama at Birmingham in Birmingham, Alabama. Dr. Farley is a professor in the School of Nursing at Johns Hopkins University and a nurse practitioner in the Department of Infectious Diseases at the John G. Bartlett Specialty Practice in Baltimore, Maryland. In this episode, they will answer questions and discuss key considerations when determining PrEP candidacy, choosing among PrEP options, and addressing PrEP persistence for individual patient. For the full online educational program, please visit the link in the show notes for this episode. Now let's get started and hear what Dr. Elopre and Dr. Farley have to say. We've had a number of questions come in already. The first question is about the longest time that somebody can be on antiretrovirals, and I'm going to take this to mean PrEP. So is there a limit to how long somebody can be on antiretrovirals for PrEP?
No. You can just need to monitor, obviously, if their renal and bone parameters as described. But no, there's no length of time someone is restricted to taking PrEP.
And I would just add that, this is the same type of therapy that we provided for decades for people who are living with HIV. So we know that they can be healthy receiving this medication for long periods of time, and it's very safe.
Great, thank you. Karen asks, does the U equals U concept apply to people who inject drugs and other non-sexual transmission routes? And if so, how strong is the data?
Well, so the original trials definitely are based on sexual transmission. There's the Partners study. There are several HPTN studies that are available. That data is all around sexual transmission. I have not seen a definitive trial for people who inject drugs in which direct blood-to-blood exposure is fully prevented by someone having an undetectable viral load. But Dr. Elopre, I don't know if you're familiar with any.
No, I would say that right now, U equals U, our data is pretty robust in sexual transmission and not so much in other routes of transmission. And even in the updated HIV treatment guidelines for pregnant populations now, they still like to emphasize the fact that we think that U equals U would apply, but that we can't say that the transmission risk is absolute zero. So that we enter a shared decision-making model when we're talking about, in the United States, decisions around breast or chest feeding. And so, I would definitely say that U equals U, the strongest data is for sexual transmission.
Yeah. And then one other thing is we often forget that our patients who are using substances of any type, particularly those who are injecting drugs, are also at sexual risk. So, the messaging certainly applies to their sexual lives, although the data is not as strong for their injection lives.
Thank you. Related to HIV prevention, what is the important relevance of circumcision for adult males?
Yeah, it's part of our toolkit. So yeah, I have to admit, you guys are surprising us with the questions. We thought they were going to be about which various PrEP options. But yes, so in communities with low levels of circumcision, like the work that I do in South Africa, there are many reasons why male medical circumcision are recommended, I think. The first is just biologically, we know that the foreskin of the penis contains a lot of dendritic cells. Dendritic cells are one of the antigen-presenting cells that ultimately bring in HIV and expose it to the right immune cells to cause replication. So removing of that foreskin decreases the number of dendritic cells. It also causes keratosis of the actual head of the penis, which decreases the likelihood you're going to get a significant amount of abrasions or other forms of cuts in that really friable skin that is protected when it's not circumcised. Then culturally, the practice of circumcision often involves progression to manhood for many cultures of the world, and it is often done traditionally. So that's done under very non-aseptic practices with non-aseptic instruments that are often include the circumcision of multiple boys in a row without necessarily changing instruments or sterilizing those instruments. So from a cultural perspective, the male medical circumcision campaign is really focused on helping to improve the aseptic technique associated with cultural practices, improving and allowing those practices to continue in many environments, but also doing so more safely. And then finally, in terms of total population risk reduction, as you look at the uncircumcised group of people versus a community randomized trial with a larger proportion of circumcised men, you see anywhere from 60+% risk reduction when communities have greater levels of circumcision in their men.
I can't answer that better. That's why I defer to you.
Hopefully that's what you were looking for with the answer to that question.
Thank you. That was great. Is there a recommendation to get a baseline DEXA, or what specifically is recommended for monitoring bone health while on PrEP?
There's not a recommendation for a baseline DEXA. So this is actually interesting. I will say that when you're talking about your different regimens, TDF FTC versus TAF FTC and cabotegravir, we know that TDF FTC is associated with decreased bone mineral density. It wasn't statistically significant, but there were some cases where people did have fractures who were over the age of 50 in clinical trials. So typically what I will do is when I'm talking to my patients about PrEP options, I present all the PrEP options, but for individuals that I know are at greater risk for having lower bone mineral density at baseline, I'll look at other factors like, do they have hyperlipidemia? Are they at risk for metabolic syndrome? Potentially, if not, then TAF FTC would be a good oral option for them. And then I had one individual who I actually gave cabotegravir to because they were over the age of 50, had a history of smoking. I was worried about bone mineral density. I did not want to give them TAF FTC, and instead we opted for CAB. So I would say you would do baseline recommendations in regards to DEXA screening, but just realizing what PrEP modalities you offer and how they can impact your bone health.
Yeah, I think this is a really great question in terms of really thinking about our clients who are over the age of 50 and the shared decision-making options, really presenting each of these options, talk about the pros and cons of each, and really come to consensus together. I have to say that several of my patients over 50, when we have that similar conversation, will opt for the drug that's the cheaper. I've repeatedly had patients who really do want to go with generic versions of TDF FTC just simply because of copay issues.
And I've had prior authorization denied, even when I put the justification in, this is why we're choosing TAF FTC. So there's a lot, I think, that goes into that. So yeah.
Oftentimes they will want a trial of TDF FTC first before they'll approve the TAF FTC. So it's always there in your back pocket. It's a cheap, it's great drug. It's on multiple formularies. So it's always there as your go-to. It's kind of like the metformin for diabetes, if you will.
I like that analogy.
All right. Jorge asks, do you recommend PrEP in pregnancy?
Yes.
Take it away. That's all you.
It is definitely safe during pregnancy and peripartum. I think that the really interesting part of this question is when you're talking about HIV serodiscordant coupling. So, we know that, again, U equals U for sexual transmission is something that there has been robust clinical trial data support and demonstration open label trials to support. In saying that, I have tons of patients who want to be on PrEP and they're in serodiscordant relationships and their partner is virally suppressed because they want that extra layer of protection. Because of our experience in treating people who are living with HIV, who become pregnant with, again, these same types of ART regimens, we know that it's safe. There's no issue. So the only one that you recommend during pregnancy is TDF FTC. The other regimens are not currently recommended.
Okay. And Kelly asks, would you describe any medication resistance, so concern for medication resistance when using non-daily medications?
So I would say that across any regimen in which there is less than perfect adherence, and I'll define that in a second, but if, for example, a patient, I'm assuming you're replying to the 211 TDF FTC related data. So TDF-FTC, remember, is the only regimen approved for the 2-1-1 regimen or the on-demand regimen. And just so we're all on the same page, that's 2 pills, 2 to 24 hours before the sex act, 1 pill 24 hours after that, and then another pill 48 hours after the original sex act. And if sex continues, you basically just continue the taking of that medication. And in many of the studies, patients virtually get 4 or more doses in a week when they take the 2-1-1 on-demand strategy. And we know that from our original data on TDF-FTC, that 4 or more doses per week is what we really need as the minimum threshold for, excellent protection, like that whole 98 to 99% that we often see. So in the circumstances of a patient who's unwilling to take 4 or more doses in a week, 2-1-1 strategy, because might be right for them when they have episodic sexual activity, we don't generally see more resistance emerge in that population who is taking it consistently prior to sex than we do in anyone who is non-adherent to their daily PrEP regimen in general. But when we do see breakthrough, there are a couple of mutations that we're concerned about. Obviously, we're concerned about an M184V and a K65R, which would be 2 main mutations that would have come as a result of a TDF-FTC-based regimen. If we're talking about cabotegravir, the integrase inhibitor resistance that will follow, can certainly see breakthrough with patients who are late or not receiving on-time injections. And sometimes even for all of these regimens, we can see resistance breakthrough, even with perfect adherence. So I have a case in a patient who speaks in one of my classes who was on the 2-1-1 regimen, took it religiously exactly as prescribed, and then developed a breakthrough case of HIV infection on 2-1-1, but not because of non-adherence to a 2-1-1 strategy, but because it is now believed that the exposure, the person who exposed him had an M184V mutation at the time. And so there is a little bit of concern of, if there's a lot of resistance in the community in which you're having sex with, that the efficacy of PrEP might be lower, in that given population. But again, that's not the norm. That would be under a very specific circumstance.
And I'll say for oral PrEP, we still have good single tablet regimens that people can take if they do develop an M184V mutation. So I'm not as concerned with my patients who are on oral PrEP with things like you've been potentially infected with a resistant strain or you've developed a resistance. I know I still have regimens that I can provide if they were to be diagnosed with HIV that are still evidence-based. Right. I think for integrase, it's a little stickier.
Yeah, for sure. We are actually looking at protocols on how for someone on the injectable form of PrEP every 2 months, that kind of creating an early warning system. Hey, you're 2 weeks before your next injection, you're 1 week before your next injection, particularly if the appointment's not scheduled. And then if an appointment's missed, really trying to work hard with our community health worker team to get them in for an evaluation within that 7-day window. But really trying to do an early kind of warning system of, hey, you don't have an appointment scheduled, you're 2 weeks out from your next injection, to preempt, reducing the potential for missed or late doses.
Okay, going along with 2-1-1, John asks, is there any data regarding FTC TAF with 2-1-1?
There's supposed to be a trial.
Not published.
Not published. Theoretically speaking, I think people think that it will be effective.
For those of you less may be familiar with the data, the reason we need a separate trial, even though tenofovir alafenamide is a prodrug of tenofovir diproxyl fumarate, is the fact that of the way in which the drug concentrates. TDF is in the plasma more, TAF is in the intracellular more, which is why you get less renal and bone complications with TAF than TDF. So there is a theoretical or biologic plausibility that you might have less reduction in infection because of that intracellular concentration resulting from TAF. And that's the reason for the trial and why we can't say definitively until those results are completely available and peer-reviewed.
All right. Karen asks, as the guidelines recommend PrEP for people who inject drugs, what is the anticipated level of risk reduction of HIV acquisition?
That's a great question. Bangkok trial is the only trial that we have in regards to people who inject drugs, and the effectiveness was slightly reduced. I can't remember the exact effectiveness. I want to say it was around 80%.
I think it was high 70s, low 80s.
high 70s, low 80s. And ultimately, that is kind of what we extrapolate our data based off of, saying that we think it's effective for people who inject drugs. And I will add that for people who inject drugs, that's why we also only recommend, again, TDF FTC. We have not done trials that include that special population for CAF FTC or for cabotegravir.
Okay. And then there's a question whether HIV is considered curable in kids versus adults and how long follow-up would be involved.
It's not. There was that famous case of, I think they called it anecdotally like the Mississippi baby, where they thought that potentially we had cured HIV because this baby had received ART so early. And unfortunately, that incident with that child, they did become viremic later on. So we do not have a cure for children at this point in time, regardless of how soon they receive ART.
And of course, there has been lots of reports of the 4 adults who have been cured of their HIV, but they were cured through bone marrow transplantation, which is not a modality that is available to anyone without the need for a bone marrow transplant.
Nor do I think you want a bone marrow transplant.
Nor do I think you want that. No, you don't.
Okay, and then Juan asks, what about adherence? I think this is asking, are there inequities in adherence and persistence in different racial and ethnic groups?
There are inequities in regards to persistence. Specifically, there have been trials looking at Kaiser Permanente and trials done in Southeastern locales. Specifically, I know one done in Emory where you saw, even in a perfect model where PrEP is essentially free, we had issues with persistence, especially among Black, gay, and bisexual men. So we focus a lot on uptake because we are underprescribing, our coverage is low, and we know that there's major barriers to access. But once an individual does go through those hurdles, accesses PrEP, we know that there are also inequities in who persist in care.
Yeah, I think we've published data similar to the Emory data in Baltimore, showing that PrEP persistence, 75% of the patients who initiated PrEP in a given year did not complete all 4 visits during that year. So, lability and persistence, starting, stopping, a patient, has a season of risk and then, settles down for the partner for a slight period of time, finding then there's barriers to get re-engaged in care. And, I tell my patients when they decide to stop PrEP or take a holiday from PrEP, that I welcome them back with open arms anytime they're ready. And I say, you might think, this particular relationship that's, 6 months in, you guys have decided to stop your PrEP. Hopefully this becomes something that's lifelong. If it doesn't, things happen. Feel free to come back. There's no shame in this game. The door is always open. Because I think a lot of people, when they decide to stop PrEP and then that relationship maybe doesn't last as long or peters out, often feel a sense of shame coming back into the PrEP program. And I try to avoid, right up front, just say that that's not something that is a shameful experience. It's actually exactly what I would hope you would do.
Great. Bernard asks, are there any meds for patients on a fixed income?
Tenofovir FTC is available in a generic form, and it is available on most prescription plans with no copay. And if a patient's even uninsured, it is available at $4 per every 30-day prescription in certain pharmacies.
Great. And then Karen asks, patients on PrEP may be admitted to the hospital where they do not have the PrEP agent on formulary. What do you suggest should be done in those cases?
I think it differs based off of what agent they're on. CAF FTC, you can definitely switch somebody to TDF FTC. It's fine. And that's what I would recommend that you would do if they were interested in continuing. And remember, you have these window periods of how long you have someone in the hospital, and we still think potentially you have PrEP on board. So if you were to stop PrEP, the counseling you'd have to give them to once you reinitiate, we recommend that it's 7 days or 21 days based off anal versus vaginal exposure of when we think you have enough PrEP on board that you're protected if you were exposed to HIV. For cabotegravir, that's actually a very interesting question. If they're within the window of their dosing, I think that it's fine. You don't have to continue. We know that they're covered. So I think I would only be concerned if there was like a prolonged hospitalization that is going on. And if that were the case, then probably there are other issues in play that I wouldn't be worried about PrEP potentially.
Just to add one thing, if the patient reported a recent high-risk sexual encounter while on PrEP and you have no version of PrEP, because after that high-risk sexual encounter, my general rule of thumb when they're thinking about stopping PrEP would be finish a full month's course after a high-risk encounter. That's surprising the number of times that comes up of when can I stop? And then you ask that sexual history, and it turns out the most recent high-risk sexual encounter was in the last 72 hours. But you would definitely want to try to cover that period of time if there's recently been a high-risk sexual encounter. If not, then I agree exactly with Dr. Elopre on those comments.
Hey, Holly asks, what are your thoughts on patients with CKD who have higher BMIs? Would you renally dose adjust an oral regimen or use cabotegravir?
So I think there are issues on both sides of the coin, right? Higher BMI may be problematic for cabotegravir. Not only does the needle length have to be correct to give intramuscular injection, but there's also some data that suggests that patients with higher BMI might get less efficacy out of the cabotegravir injection. So on that side, on the obesity side, there's that issue. On the renal insufficiency side, that would be a perfect reason to use tenofovir alafenamide, which has, is much more friendly. I won't say completely friendly, but more friendly to the nephron than tenofovir diproxyl fumarate.
Okay, and then Mohit asks, which of these PrEP regimens should be the most readily available across U.S. patient populations? While PrEP regimens are tailored to individuals, what is your most commonly prescribed medication?
TDF-FTC, 100%.
Yeah. We still have, I would say, several patients wanting injectable PrEP in our practice. There are many reasons why you just can't send a patient a prescription for injectable PrEP. It is a medical benefit, not a pharmacy benefit, and therefore it must be administered through your clinic at this time. It can't be just called into your local pharmacy and administered through the pharmacy. There's also some restrictions depending on your state about whether or not pharmacists can actually administer the injection or not. So there are some barriers there. So you know that if a patient wants injectable PrEP, and many of my patients have asked me about it and want it, even still getting that prior authorization approval for them to switch is an uphill battle. So I have to say that I was just talking to a friend in New York City at one of the largest LGBTQ practices there. And he had mentioned that he has very few patients who have made it successfully into injectable PrEP thus far. And I've had the same experience in our practice, even despite patient desire.
I think we have like 7 patients right now that are getting cabotegravir, and they have premier insurance coverage.
All right. Kirby asks, can you elaborate on contraindications in certain PrEP options for people who inject drugs?
I think it's just because we don't have that population involved in the clinical trials. I think there's some questions about, for instance, we know for post-exposure prophylaxis, when we're talking about the time it takes to get into, we were saying that intracellular level versus having it extracellular. Some people don't like to use TAF-based regimens in regards to acquisition related to intravenous drug use. And so instead we use TDF-FTC. And so I think it's just the question of, we need data. We need data to say it's going to be effective at prevention of HIV infection if you were exposed based primarily off of blood, intravenous drug use.
I think the harm reduction framework is so critical there. So clean needles, needle exchange as much as possible, and using TDF-FTC and offering TDF-FTC for clients who may be still exchanging needles or engaging in exchange sex for drugs, for example. So remember the sexual risk as well. And I know that you will be getting benefit if the client is able and willing to take daily TDF-FTC. It's just going to be more protective for their sexual risk than for their injection risk.
And then Monica asks, is there data in regards to which PrEP medication would be best for a cisgender man that has sex with a transgender man?
I think it would be based off the site of exposure, what type of sex they were engaging in. And for the cisgender man, I think, we know data in regards to insertive vaginal and insertive anal sex, where we have multiple oral PrEP modalities that have been approved now for that. So I think that's kind of what it would be based off of. We have very little data in regards to trans men and their overall likelihood of being diagnosed with HIV on PrEP, but we base it off of what we've done with other populations, and we do include them as a population saying is approved for this. So I would just base it off of the site of exposure in regards to what PrEP option you would use. Does that make sense?
Yeah, I agree. Just in terms of trans health in general, understanding and knowing, which hold is used for sexual exchange would be really important in that scenario, and then modifying the PrEP options based on that.
Okay, and then last question, Herbert asks, is event-driven PrEP effective for assigned male at birth who is the anal receptive partner or bottom?
Yes.
Yeah.
So any person, it sounds like you assigned male at birth, receptive bottom partner, so a cisgendered gay man, yes, those studies have definitely been done looking at top or bottom positioning and works fine.
Thank you very much to Drs. Elopre and Farley, and thank you to our listeners for joining in. Please be sure to check back regularly for more episodes on important infectious disease topics. Thank you and have a great day.